All right, guys, welcome to chapter 27, soft tissue injuries. This is one of those chapters that on the surface might seem pretty straightforward. Like, okay, it's cuts and bruises, burns, got it. But I want you to shift your mindset a little because soft tissue injuries are actually some of the most common and sometimes most dangerous things that we're going to see in the field. Think about it. Every trauma patient you encounter has some form of soft tissue involvement. Whether it's a simple abrasion or a life-threatening hemorrhage, this chapter is going to tie together directly how you assess, prioritize, and manage trauma patients. And here's the big thing I want you to keep in the back of your mind as we go through this. Bleeding can kill your patients long before anything else does. So while some of this may feel basic, the decisions you make with soft tissue injuries, especially bleeding control, are absolutely critical. All right, before we jump into the actual content, let's ground ourselves in what the National EMS Education Standards expect from you when it comes to trauma. At the EMT level, trauma isn't just about recognizing injuries. It's about applying fundamental knowledge to actually take care of your patient. And I want you to really hear this wording. Provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Everything in that sentence matters. First, assessment findings. That means you're not just reacting, we're thinking. We're using our primary assessment and our rapid trauma assessment and everything we're seeing and hearing to guide what we do next. Second, basic emergency care. This is our bread and butter. This is bleeding control, airway management, shock management, the things that truly save lives in those first few minutes. And third, transportation. You're not just treating. You're constantly deciding, where does this patient need to go? How fast do they need to get there? Is this a load and go, or can I stay and play for a minute? So as we go through this chapter on soft tissue injuries, I want you to keep tying everything back to this competency. This is still part of the National EMS Education Standards. Just now, we're zooming in a little bit though, specifically on soft tissue trauma. At the EMT level, you're expected to be able to recognize and manage several key types of injuries. That includes wounds, different types of burns, as well as chemical exposures to the skin and eyes. So again, this isn't just about knowing definitions. It's about being able to identify what you're seeing and take appropriate action. When you're walking up on scene, you should be able to quickly say, okay, what type of injury is this and what does my patient need right now? Whether it's a laceration, a burn, or a chemical exposure, your early recognition and management are what set the tone for the rest of the patient's care. Continuing with these standards, we're getting a little more detailed. This is where you're expected to understand not just what the injuries are, but the pathophysiology, assessment, and management behind them. We're going to dive into different types of wounds like avulsions, bite wounds, lacerations, punctures, and incisions. Each of these might look different, behave differently, and require slightly different approaches in how you manage them. And this is where your role really starts to level up because now it's not just that's a wound. It's what kind of wound, what's happening underneath, and what does my patient need right now? The last piece of the education standards for this chapter, and this continues the same idea, understanding the pathophysiology, assessment, and management. But now we're applying it to burns and crush injuries. So when it comes to burns, you need to be able to recognize and manage different types. Electrical, chemical, thermal, and even radiation. And remember, burns aren't always just what you see on the surface, especially with things like electrical burns. There can be a lot more going on internally than what's visible inside. We're also going to talk about crush syndrome, which is a big deal in certain trauma situations, especially prolonged entrapments. This is one of those topics where understanding what's happening inside the body really matters for how you manage the patient. So again, this is all about building on that same foundation. You're assessing, you're identifying what type of injury we're dealing with, and you're making decisions based on what's happening beneath the surface, not just what you can see. Let's start with the big picture when it comes to soft tissue injuries. First, these are incredibly common. You're going to see them all the time in the field, and they can range from anything like something minor, a cut or a scrape, all the way up to something that's life-threatening, especially when there's significant bleeding or internal injury involved. Now, here's a really important mindset piece, and this is where you sometimes get tripped up. Do not get distracted by dramatic-looking wounds. Some injuries look really bad. Lots of blood, large open wounds, and yeah, they absolutely need to be addressed. But if you let that pull all your attention, you can miss something even more critical. For example, an airway obstruction. Your patient could have a nasty looking external injury, but if their airway is compromised and you miss it, that's what's going to kill them first. So this is where we anchor back to our priorities: airway, breathing, and circulation. Always follow our assessment and always treat our life threats first. So as we move forward, keep that in mind. Don't chase what looks the worst. Treat what is the worst. Building on that, let's talk about how soft tissue injuries actually happen. Soft tissues can be damaged through a variety of mechanisms, and understanding the mechanism of injury is huge because it helps you predict what's going on beneath the surface. We're looking at a few main categories: blunt injuries, things like falls, car accidents, or getting struck by something; penetrating injuries where something actually breaks through the skin, like a knife or a gunshot wound; barotrauma, which involves pressure changes, not something that we see every day, but still something we should recognize; and then burns. We'll spend a good bit of time on that later. So don't just memorize this list. We're going to use it. When you're on scene, we should ask ourselves, what happened to the patient? What kind of force was involved? And what could this have done internally? Because the mechanism tells a story. And the better that you understand that story, the better your assessment and treatment decisions are going to be. Wrapping up this introduction, let's hit on a few key takeaways. First, again, soft tissue trauma is extremely common. This is something you're going to see on a regular basis across all types of calls, because here's where it gets serious. Death is often related to hemorrhage or an infection. We've already talked about bleeding, and you'll hear me say it over and over. Uncontrolled bleeding can and will kill your patient quickly. That's why rapid recognition and control is such a priority. And then there's infection, which may not be immediate, but absolutely is a concern, especially with open wounds and burns. And lastly, a lot of these injuries are actually preventable. Simple things like protective equipment, safety practices, and awareness can make a huge difference. So that's something to keep in mind, not just for your patients, but for yourself as providers too. Let's start with the basics: the anatomy and physiology of the skin. Your skin is actually the body's first line of defense. It's constantly protecting you from things like external forces, so trauma, but also infection. So when that barrier gets disrupted, whether it's from a cut, a burn, or anything else, your body is suddenly a lot more vulnerable. Now, the skin is pretty tough, and it can handle a lot, but it's not indestructible. And injuries can range anywhere from something minor, like a bruise or abrasion, all the way up to something more severe, like deep lacerations or even amputations. So as we go through this section, I want you to keep that in mind. When the skin is damaged, it's not just a surface problem. You're potentially losing protection against infection, losing fluid, and in some cases dealing with significant bleeding. And that's why even simple skin injuries can become serious if they're not managed appropriately. So this slide really brings it back to your role as an EMT, what you're expected to do every single time you're dealing with soft tissue injuries. There's a few core principles that you should always be thinking about. First, control the bleeding. This is your number one priority when it comes to soft tissue trauma. If your patient is bleeding, you need to address that immediately. Next, prevent contamination. Anytime the skin is broken, there's a risk for infection. So we want to keep things as clean as possible and limit further exposure. Then protect the wound from additional damage, whether that's covering it, stabilizing it, or just being mindful during movement. We don't want to make things worse. And finally, apply appropriate dressings and bandages. This is where your skills really come into play. Choosing the right type of dressing and securing it properly based on the location and severity of the injury. So if you ever feel overwhelmed on a call, come back to these basics: bleeding, contamination, protection, and proper dressing. If you handle those well, you're doing exactly what your patient needs in that moment. One important thing to understand is that the skin isn't the same everywhere on the body. It actually varies quite a bit in thickness. For example, skin tends to be thinner in very young and very elderly, which makes those populations more susceptible to injury. It's also thinner in certain areas like the eyelids, lips, and ears, compared to the thicker areas like the scalp, back, or the soles of our feet. And this really matters clinically. Thinner skin is going to be more fragile, more easily injured, and sometimes it'll bleed more. It can also affect how wounds look and how they heal. So when you're assessing a patient, keep location and their age in mind because not all skin injuries are going to behave the same way depending on where they occur. The skin is made up of two main layers, the epidermis and the dermis, and understanding the difference between these two is really important. The epidermis is the outer layer. This is what you see. It's relatively tough. It acts as that first barrier against the outside environment. Under that is the dermis, which is the inner layer. This is where things get more complex. You've got blood vessels, nerve endings, and other structures that support the skin. And this distinction matters when we start talking about injuries. A superficial injury may only involve the epidermis, but once you get into the dermis, you're more likely to see bleeding, pain, and more serious damage. So as we move forward, especially when we get into burns and deeper wounds, keep those layers in mind because they directly impact how severe an injury is and how you manage it. Take a look at this image. This is a really helpful visual of what's actually going on beneath the surface of the skin. You can clearly see the epidermis on top and the dermis underneath. But what's important here is everything that lives within that dermis layer. This is where you find things like blood vessels, nerve endings, hair follicles, sweat and sebaceous glands, and then even deeper, we have the subcutaneous tissue, which includes fat and connects down to the muscle. Why this matters for you as an EMT is because when an injury goes deeper than just the surface, you're not dealing with just the skin anymore. Now we're dealing with bleeding from blood vessels, pain from nerve involvement, and potential damage to deeper structures. It also helps explain why some injuries bleed a lot and others don't. It depends on how deep they go. So when you're assessing a wound, don't just look at how big it is. Think about how deep it might be and what structures could be involved underneath. Another important concept to understand is that skin covers all external surfaces of the body. It's your primary protective barrier. But not every surface is covered by typical skin. Areas like the mouth, nose, eyes, and other body openings are lined with what we call mucous membranes. These membranes serve a similar purpose. They act as a barrier against bacteria and other pathogens, but they're more delicate than regular skin. And this matters for you in the field. These areas are more vulnerable to infection and injury, and they require a little extra care when you're assessing and managing patients. So anytime you're dealing with injuries involving the eyes, mouth, or other openings, just remember, you're not dealing with the typical skin, and your approach might need to adjust accordingly. The skin does a lot more than just sit on the outside of the body. It actually serves several really important functions. First, it acts as a barrier against infection, helping keep bacteria and other harmful substances out. It also is a sensory organ, which means it allows you to feel things like pain, pressure, heat, and cold, all of which are important when you're assessing injuries. The skin also plays an important role in temperature regulation. Through things like sweating and blood flow, your body is constantly working to maintain a stable internal temperature. And finally, it helps maintain fluid balance. While the skin is intact, it keeps fluids where they belong. But when it's damaged, especially in burns or large wounds, patients can lose fluids quickly, which can lead to shock. So again, when the skin is injured, you're not just dealing with a surface issue, you're potentially affecting multiple systems at once. Anytime there's a break in the skin, you need to start thinking beyond just the visible injury. That break creates an entry point for bacteria, which increases the risk of infection. You can also see fluid loss, especially with larger wounds or burns, and that can contribute to shock if it's not managed. And then there's temperature control. When the skin is damaged, the body loses its ability to regulate heat effectively, which can put your patient at risk for hypothermia, even in environments where you might not expect it. So again, even a seemingly simple injury can have bigger implications. To wrap up this section, soft tissue injuries fall in three main categories. You've got closed injuries, where the skin remains intact, things like bruises and contusions. Then there's open injuries, where the skin is broken, and that's where you start dealing with bleeding and increased risk of infection. And finally, burns, which are their own category because of how they affect the body, not just locally, but systemically as well. As we move forward, everything we talk about is going to fall into one of these three groups. This is a simple framework, but it's really helpful when you're on scene. Quickly identifying what type of injury you're dealing with helps guide your assessment and your treatment right from the start. This slide walks you through the basics of wound healing. First, the body works to stop the bleeding. That's the immediate priority. Next comes inflammation, which is a normal response as the body starts cleaning up damaged tissue. After that, new cells begin to move in the area and new blood vessels form to support healing. Finally, collagen is laid down, helping strengthen the tissue and close the wound. To the big picture, the body has a process. Your job is to support it by controlling bleeding, protecting the wound, and preventing complications along the way. Closed injuries are injuries where the skin stays intact, but there's still damage underneath. A contusion or bruise is the bleeding under the skin without it breaking. A hematoma is a step further. That's when blood actually collects in the tissue or a body space. And then you have crush injuries, where a significant amount of force is applied to the body, often causing deeper tissue damage. So even though you might not see an open wound, don't let that fool you. There can still be significant internal injury that needs to be recognized and managed. With crush injuries, time really matters. If a body part is trapped for more than about 4 hours, you have to start thinking about crush syndrome. What's happening is the damaged muscle cells begin to die. And when that happens, they release harmful substances into the surrounding tissue and eventually into the bloodstream. And that's where this becomes dangerous. Once that pressure is released, those toxins can circulate and cause serious complications. So these aren't just local injuries. They can quickly turn into a systemic problem. And that's something you should always be thinking about when you're dealing with prolonged entrapments. Another complication to be aware of with closed injuries is compartment syndrome. This happens when swelling builds up in a confined space, increasing pressure and limiting blood flow to the tissues. Left untreated, that can lead to serious damage. Also, keep in mind, severe closed injuries can still involve internal organs, even if you don't see anything obvious on the outside. So your takeaway here is simple. Don't underestimate closed injuries. Always assess thoroughly and stay alert for hidden, more serious problems beneath the surface. Now, shifting into open injuries, these are injuries where the skin is actually broken. So now you're dealing with bleeding and a direct pathway for infection. You've got more superficial injuries like abrasions where the top layer is scraped away. Then lacerations, which are cuts that can vary quite a bit in depth and severity. Avulsions are more serious. That's where the tissue is torn away, sometimes partially or maybe even completely. And then there's penetrating injuries, where something enters the body, and those always raise concern for deeper damage that you might not immediately see. Starting with abrasions, these are probably the most common type of open injury you'll see. Think of these as scrapes. They involve the very top layer of the skin and are usually caused by friction, like when someone falls and slides across the pavement. Even though they're considered superficial, they can still be painful and may have some minor bleeding, usually more of an oozing from the capillaries rather than a heavy bleeding. But something to keep in mind, because that top protective layer is gone, abrasions carry a high risk for contamination and infection, especially if there's dirt or debris involved. So while these are simple injuries, it's still important to manage them correctly. Next up are lacerations and incisions, and these are both types of cuts, but they're a little different in how they present. A laceration is what you'll most commonly see in trauma. It's a jagged, irregular cut, often caused by a blunt force or tearing. An incision, on the other hand, is a clean, smooth cut, usually from something sharp like a knife or glass. Now, here's where this matters clinically. Lacerations can vary quite a bit in depth, and some can extend down into the muscle, nerves, or blood vessels. So don't just assume it's minor just because it's just a cut. And depending on what caused the injury, these wounds may be messy, contaminated, or bleed significantly. So your focus is control the bleeding, assess how deep it might go, and protect the wound. Because even something that looks straightforward on the surface can involve deeper structures underneath. Avulsions are more serious open injuries. This is where layers of soft tissue are torn away, either completely or partially, leaving tissue hanging as a flap. These injuries are often associated with significant bleeding and can look pretty dramatic. What's important here is recognizing the severity and managing it appropriately. You want to control the bleeding quickly, and if there is a flap of tissue, try and preserve it by placing it back in the position if possible and covering with a sterile dressing. Also, keep in mind, because of the amount of tissue damage, these wounds have a high risk for infection and complications. So your priorities are controlling the bleeding, protecting the tissue, and preparing for rapid transport if needed. Two more types of open injuries to be familiar with are amputations and penetrating wounds. An amputation is exactly what it sounds like. A body part is completely severed. There are high acuity injuries and involve a major risk for severe bleeding, so rapid bleeding control is critical in these situations. A penetrating wound occurs when an object enters the body, and what you see on the outside may be very small compared to the damage underneath. The key with these injuries is don't underestimate them. With amputations, you're thinking aggressive bleeding control and proper care of severed parts. With penetrating trauma, you're thinking about what structures could be involved internally and managing them accordingly. So even if the external injury doesn't look dramatic, there's potential for serious internal damage. When you're dealing with stabbings or shootings, it's important to expect more than what you see at first glance. These patients often have multiple penetrating injuries, so you need to be thorough in your assessment. That means fully exposing the patient when appropriate and carefully looking for all wounds, not just the obvious wounds. You also want to count how many penetrating injuries you find, because that can help guide your understanding of what's going on internally. And if it's a firearm-related injury, gathering information about the type of wound, type of weapon, if possible, can give you clues about the potential severity and damage. The bottom line, don't get tunnel vision on just one injury. Take a step back, assess completely, and make sure you're not missing anything. Blast injuries are a little different because there are multiple ways a patient can be injured from a single event. A primary blast injury comes from the blast wave itself. That sudden pressure change can damage organs, especially air-filled ones like the lungs and the ears. A secondary blast injury is caused by flying debris, essentially turning objects into projectiles that can penetrate the body. And then there's that tertiary blast injury, where the patient is actually thrown by the force of the explosion and injured when they hit another object. So with these patients, you're not just looking for one type of injury, you're thinking about multiple mechanisms happening at the same time. That means a thorough assessment is critical because there may be both external and internal injuries that aren't immediately obvious. When it comes to assessment, closed injuries are often more challenging than open ones. With an open injury, you can usually see what you're dealing with, but closed injuries require you to look a little deeper and pick up on more subtle clues. Things like bruising, swelling, or deformity should be immediate big concerns for you. And don't overlook your patient's report of pain. Pain is a big indicator that something may be going on underneath the surface. So this is where your assessment skills really matter. You're putting together what you see, what you feel, and what the patient tells you, and using that to identify injuries that aren't always obvious at first glance. Scene size up always comes first. No matter what type of call you're on, your top priority is scene safety, making sure it's safe for you, your crew, and your patient before you even make contact. And then you're thinking about mechanism of injury. As you approach, start looking for clues. What happened here? What forces were involved? What does the scene tell you about potential injuries? The MOI can also alert you to hidden dangers, both for you and your patient. And based on what you found, you should be asking yourself, do I need additional resources? Is this a situation that could escalate? So before you ever lay hands on your patient, you're already building a picture of what you're walking into and what you need to be prepared for. The primary assessment is where you identify what's going to kill your patient first and how quickly they need to be transported. You're looking for life threats right away and deciding, is this patient critical? At the same time, you're forming a general impression. That starts the moment you see the patient. How do they look? Sick or not sick? Stable or unstable? You're also watching for any signs of serious head and injuries, especially in trauma where not everything is obvious. And don't forget to check responsiveness early on. That gives you a lot of information about your patient's overall condition. So this is a fast, focused, and intentional assessment. You are not getting into details yet. You're identifying priorities and setting the direction for everything that comes next. Focusing on circulation. This is where priorities can shift quickly in trauma. If your patient has significant bleeding, that becomes your immediate life threat. And it may need to be controlled even before you move to the airway. So if you see obvious life-threatening external bleeding, the steps are pretty clear. First, control the bleeding. That always comes first. Then move into your airway management, making sure that your patient can maintain it. At the same time, you should already be thinking about shock, assessing for it, and starting treatment early. So this isn't always that strict ABC order. In trauma, especially with severe bleeding, it often becomes more of a CAB approach or an XABCs approach, because if you don't control the bleeding, nothing else matters. Moving into airway and breathing, this is where you make sure your patient can actually oxygenate and ventilate effectively. First, confirm that the airway is open and clear. At the same time, you want to be mindful of spinal precautions, especially in trauma patients. So protect the spine as you're managing the airway. Then assess for adequate breathing. Are they breathing enough? Is it effective? If not, you need to step in and manage it with oxygen or assisted ventilations. And don't forget to assess the chest. Look and feel for any signs of injury using that DCAP BTLS mnemonic, because chest trauma can directly impact breathing. So this step is all about making sure your patient can move air in and out and stepping in quickly if they can. The last part of the primary assessment is your transport decision, and this is happening early. Based on what you've seen so far, you're deciding, does this patient need to go now? Certain findings should immediately push you towards a rapid transport. Things like a poor general impression, an altered level of consciousness, or difficulty breathing. Abnormal vital signs, signs of shock, or severe pain are also big red flags. So this is where everything comes together. You've done a quick assessment, now you're making a decision about the priority and moving to definitive care. Because at the end of the day, your goal isn't to fix everything on scene, it's to recognize what's wrong and get your patient where they need to be as quickly as possible. Once you've completed your primary assessment, you move into history taking. This is where you start digging into that chief complaint and gathering more information to guide your care. You'll use tools that you're already familiar with, sample, OPQRST, DCAP BTLS, to build a well-rounded picture of what's going on. If your patient isn't responsive, you need to get that information from bystanders, family members, or other responders. And don't forget, chronic medical conditions can absolutely impact how a patient responds to a soft tissue injury and how they heal. So this step is about putting the story together, not just what you see, but what led up to it and what might affect your patient moving forward. The secondary assessment is where you slow down a bit and take a more detailed look at your patient. You're reassessing the interventions you've already done and repeating vital signs to see how your patient's responding. This is typically happening en route to the hospital once you've addressed immediate life threats. You'll also be doing a more thorough exam, going through all the anatomic regions to make sure nothing was missed during your primary assessment. This is your chance to catch anything subtle, reassess trends, and make sure your patient's continuing to move in the right direction. As part of your secondary assessment, you're performing a more focused physical exam, starting with breathing. You want to listen to breath sounds and determine their respiratory rate. But don't stop there. Pay attention to the pattern and the quality of their respirations. Are they shallow, labored, irregular? Also look at the chest. Is it moving symmetrically, or do you see uneven rise and fall? These details can give important clues about underlying injuries, especially in trauma patients. So this step is about going beyond just the numbers and really assessing how well your patient is breathing. Continuing to your physical exam, you're now expanding your assessment to other systems. Start by evaluating the neurologic system. Look at things like level of consciousness, responsiveness, or any deficits. Then move into the musculoskeletal system, checking for injuries throughout the body, deformities, tenderness, or anything abnormal. Again, this is a head-to-toe assessment, making sure that you cover all anatomic regions so nothing gets missed. This is where thoroughness matters. You're systematically working through the patient, making sure that you identify both obvious and more subtle injuries before arriving at the hospital. Vital signs are a key part of your secondary assessment, and just as important as taking them is reassessing them. You're looking for trends. Is your patient improving, staying the same, or getting worse? You also want to watch for signs of hypoperfusion or shock, things like tachycardia, tachypnea, and low blood pressure. You may also see a weak pulse and skin that's cool, pale, or moist. These findings tell you your patient may not be perfusing well and could be deteriorating. So this is where you connect the dots, using your vital signs to guide your decisions and recognize when your patient needs rapid intervention and transport. Reassessment is all about staying on top of your patient's condition as things evolve. You're going back and repeating your primary assessment, making sure no new life threats have developed. You're also evaluating how effective have our treatments been. Is the bleeding still controlled? Is the airway still patent? Is the patient improving? And you'll continue to recheck vital signs and their chief complaint, looking for any changes or trends. So this isn't a one and done process. You're constantly reassessing, adjusting, and making sure your patient is heading in the right direction or quickly recognizing if they're not. As you continue reassessing, you want to stay focused on the interventions that you've already put in place. This means going back and checking. Are they still working the way that we intend? Take a close look at bandaging, especially in trauma patients. Has bleeding restarted? Has anything loosened during movement? And overall, you're watching for any changes in the patient's condition. If something changes, our care needs to change with it. So this step is really about staying proactive, not just doing treatments, but making sure they continue to be effective and our patient moves through care. The last piece of reassessment is communication and documentation. And this is where you clearly tell the patient's story. You want to include the mechanism of injury, what may have happened, and any clues from the scene. Document the position you found the patient in, as well as estimate the size of blood loss if applicable. Be specific about the injuries, their location, size, and depth, and describe them clearly. And just as important, document what you did, the treatments you provided, and how the patient responded. This isn't just paperwork. It's how you communicate with the next level of care. A clear, accurate report ensures continuity of care and helps the receiving team understand exactly what's already been identified and managed. When it comes to closed injuries, not all of them require aggressive treatment, especially small contusions, but that doesn't mean that you should ignore them. Larger or more extensive injuries can still lead to significant internal bleeding, which puts the patient at risk for hypovolemic shock. So even if something looks minor on the surface, you still want to monitor it closely. Watch for changes, increasing pain, swelling, or any signs that your patient may be deteriorating. For managing closed soft tissue injuries, you can sometimes use the RICES mnemonic, which stands for rest, limiting movement to prevent further injury, ICE to reduce swelling and pain, compression, using a bandage to control swelling, elevation, raising the injured area when possible to decrease swelling, and splinting, to stabilize the area if there's concern for more serious injury. This is a simple, effective approach for many closed injuries. Just remember, this applies to patients who are stable and don't have more serious underlying trauma. If something seems more severe, your focus shifts back to a full assessment and transport priorities. Even with closed injuries, you always need to be watching for signs of developing shock. Early on, you might see things like anxiety, agitation, or changes in mental status. As it progresses, you'll often notice an increased heart rate and respiratory rate. You may also see diaphoresis, with skin that becomes cool and clammy. And later signs can include a drop in blood pressure, which is a more concerning finding. So this is where your reassessment and vital signs really matter. You're looking for trends and subtle changes because recognizing shock early can make a huge difference in how quickly you intervene and how well your patient does. When managing open injuries, start with the basics. Standard precautions. Protect yourself first so you can safely care for your patient. If you identify life-threatening bleeding, that needs to be addressed immediately. Apply direct pressure, and if you're working with a team, delegate that task so it's handled right away. Also, pay close attention to wounds involving the chest, upper abdomen, or upper back. These areas raise concern for injuries that can affect breathing, so they should be covered with an occlusive dressing to prevent air from entering. So your priorities here are safety, rapid bleeding control, and recognizing injuries that could impact the airway and breathing. When it comes to controlling bleeding, you want to start simple and escalate as needed. Begin with direct, steady pressure. That's your first and most effective intervention. Elevation can also help in some cases. If bleeding continues, you can move to a pressure dressing or even use a splint to help maintain that pressure. And if it's still not controlled or if the bleeding is severe, that's when you move to a tourniquet. So think of it as a progression. Start basic, reassess, and step up the interventions if needed. The goal's always the same. Stop the bleeding as quickly as possible. One thing to always assume with open injuries is that they're contaminated. Any break in the skin creates that pathway for bacteria, so infection is always a concern. even if the wound looks relatively clean. Another helpful point is that splinting can sometimes help control bleeding, even if there's no obvious fracture. By stabilizing the extremity, you reduce movement and help minimize further tissue damage and bleeding. Abdominal wounds are a high priority because of what's underneath. An open wound to the abdomen can expose internal organs, which makes these injuries more severe than they may initially appear. In some cases, you may see an evisceration, where organs actually protrude through the wound. And this is one of those situations where your management is very specific. You do not push anything back in. Instead, you want to protect the organs by covering them with a sterile, moist dressing and then securing it in place. These patients need rapid transport because this is not something that can be managed definitively in the field. So your focus is on protection, preventing further damage, and getting them to the hospital quickly. Continuing with abdominal injuries, your management is focused on protecting the wound and the organs. You'll start by covering the area with sterile gauze, ideally moistened, to help prevent the tissues from drying out. Then secure it with an occlusive dressing to keep everything in place and reduce further contamination. And a key point, you want to keep the exposed organs moist and warm. So this is less about fixing the problem and more about preserving the tissue and preventing additional damage until the patient can receive surgical care. Handle these injuries carefully and keep your focus on protection and rapid transport. When it comes to impaled objects, the general rule is simple: do not remove them. The object may actually be helping to control bleeding, so removing it can make things worse. There's only a couple of exceptions. If the object is in the cheek or mouth and blocking the airway, it may need to be removed to maintain a patent airway. Or if it's in the chest and preventing effective CPR, then removal may be necessary. Otherwise, your job is to stabilize the object in place, prevent movement, and manage the patient. So resist the urge to pull it out. Protect it, secure it, and focus on getting the patient to definitive care. Neck injuries are high risk and need to be taken seriously. These injuries can be life-threatening, not just because of the bleeding, but also because of the structures involved: airway, blood vessels, and nerves. One major concern is that open veins in the neck actually can draw in air, which can lead to cardiac arrest situations. So these wounds should be covered with an occlusive dressing to prevent air from entering. You can apply manual pressure to control bleeding, but you have to be careful. Avoid compressing both carotid arteries at the same time, as that will reduce blood flow to the brain. So this is a situation that you need to be controlled and precise, managing bleeding, protecting the airway, and preventing additional complications. Next, let's talk about small animal bites. These are actually more concerning than they might seem at first because a small animal's mouth is heavily contaminated with bacteria, so infection is a huge risk. Because of that, these wounds often require more advanced care, like debridement, antibiotics, tetanus prophylaxis, and sometimes even surgical repair. So even if the bite doesn't look severe on the surface, it should never be dismissed. All animal bites should be evaluated by a physician to make sure there's no deeper damage and properly manage infection risk. So the bottom line is to treat the wound, but always think ahead to infection prevention and follow-up care. Another major concern with animal bites is the spread of rabies. Rabies is an acute, potentially fatal viral infection that affects the central nervous system. It can affect all warm-blooded animals, including humans, and it's typically transmitted through a bite or even saliva entering an open wound. What makes rabies especially dangerous is that once symptoms develop, it's almost always fatal. The good news is it's preventable, but only if treated early with a series of specialized vaccine injections. So as providers, any suspected animal bite, especially from an unknown or unvaccinated animal, should raise concern for rabies and be taken very seriously. Now let's talk about human bites, and these are actually a bigger deal than people think. The human mouth contains an extremely wide range of bacteria and viruses, making these wounds highly prone to infection. Because of that, any human bite that breaks the skin should be treated as a serious injury. These wounds can lead to rapid spreading infections, especially in areas like the hands. So even if it doesn't look severe on the surface, don't underestimate it. These patients need thorough cleaning, proper care, and medical evaluation. So when it comes to treating open injuries like human bites, your care is pretty straightforward, but it's important. You want to apply a dry, sterile dressing to protect the wound and reduce contamination. Then immobilize the area with a splint or bandage, especially if it involves a joint or a hand, to help prevent further injury and limit the spread of infection. And finally, these patients need to be transported to the emergency department for further evaluation and treatment. Remember, with wounds like this, especially human bites, the biggest concern is infection. So early and proper care really matter. We're going to pause here for part 2.